Today we are going to discuss the laboratory aspect of stool analysis, in particular making a diagnosis of diarrheas in general. And here we need to talk about how to collect a specimen, the nature of the specimen, and the information that you can get out of what we call simply a stool analysis, then microscopy, and then in bacteria, usually we culture. And when we culture, we have to know about the media that we use in the lab, the selective media for the pathogens that they infect the gastrointestinal tract, as well as the parasites. And in the parasites, the most important part is to see the ova that is related to that type of the parasite, and sometimes parasitic segments as well. And those are so important in making a diagnosis of the main problem that involves the gastrointestinal tract, which is mainly the diarrhea. So the main complaint of a patient who has a problem in the gastrointestinal tract is usually a diarrhea. And it's very important for you to ask the patient about the diarrhea. And you have to know that it's not always the cause of diarrhea is infection with a bacteria or a virus or a parasite. So you have to make the diagnosis for the cause of the diarrhea, and then to treat that. So it's so important to know that not always the causative agent of a diarrhea is infection, but our role in the clinical microbiology lab is to rule out that the cause of the diarrhea is not infectious. So this is extremely important to know. So sometimes the diarrhea could be related to hypersensitivity, certain types of autoimmune diseases. I'm sure you are going to know about all aspects of that, cancers, for example, and so on. You have to rule out here infections, which is your first choice, and if it is not an infectious agent, then you have to look for other causes of diarrhea. The second important point that I want you to know here when a patient comes with a problem to the gastrointestinal tract is to do stool analysis. And when we do a stool analysis, it's extremely important here to look for the idea whether this type of a diarrhea is an invasive type of an agent or a non-invasive type of an infectious agent. Because here, if it is an invasive, then you have to look for certain types of infectious agents. If it is non-invasive, or what we call watery diarrhea, you have to look for other agents and to ask other questions and so on. So this is extremely important to know when we talk about the type of a diarrhea. And just simply, when we say invasive type of a diarrhea, it's just when we do the stool analysis, we look for red blood cells and white blood cells, blood and pus that's present in the fecal specimen. If those are present, this is an invasive type of a diarrhea. Then you have to think of a certain agents, Shigella, for example, Entamoeba histolytica, certain types of bacteria, Shigella, Salmonella, viruses, and so on. While if there is no red blood cells or white blood cells, and there is no blood or mucus as well in the stool, this is a non-invasive type of a diarrhea, and we have to look for other agents like Vibrio Cholera, enterotoxigenic Escherichia coli, for example, and so on. There is no direct damage to the gastrointestinal tract. Some other causes of physiological types of diarrhea, I'm sure you are so familiar with that, like stress sometimes could cause diarrhea. Some here stressful situations, so you have to take a proper history. Certain types of food, allergies, and so on could be associated with this type of a diarrhea. So it is extremely important then, after knowing this type of a diarrhea, whether it is an invasive or a non-invasive type of a diarrhea, to know the infectious agents that are associated with diarrhea. Very, very important to know. And then how to collect the specimen, and then what are the media that you need to use, and the culture, and then identification, and to make the diagnosis. So in the non-invasive type of a diarrhea, where there is no damage to the gastrointestinal tract, it's just simply water and electrolytes loss and dehydration is going to be associated with that, and death that is going to follow. On top of this list is the non-invasive is Vibrio Cholera. So Vibrio Cholera is the most important, and you know that usually it comes in epidemic format, and people they will die because of dehydration and electrolyte imbalance, and as well as here electrolyte imbalance and in general, but the most common problem of death is dehydration. So Vibrio Cholera is on top of the list, and then we have certain types of Escherichia coli that are associated here with this type of diarrhea, like for example the enterotoxigenic Escherichia coli. Enterotoxigenic Escherichia coli. You have to remember, by the way, all of the causative agents that are associated with the non-invasive as well as with the invasive type of a diarrhea. Enterotoxigenic, and then we have the enteropathogenic Escherichia coli, and then the enteroaggregative type of Escherichia coli, and the type of toxins that are produced in those, like the heat labile toxin, and we have the heat stable toxin as well with these infectious agents. Other infectious agents that could be associated with non-invasive type of a diarrhea, like here Clostridium perfringens, the causative agent of gas gangrene, can be also associated with a non-invasive type of a diarrhea in those patients. And also we have the Bacillus cereus, especially in rice dishes. Bacillus cereus can cause watery type, non-invasive type of a diarrhea. And Also, Staphylococcus aureus. Staphylococcus aureus can be associated with severe type of watery type of diarrhea. And by the way, this is what we call food poisoning. And food poisoning, just eating food that is contaminated with these infectious agents, like Staphylococcus aureus. We call it staphylococcal food poisoning. But the others, Clostridium and so on, can be associated with watery diarrhea type of food poisoning. So you have to remember then those infectious agents. So after talking about the invasive type of diarrhea, sorry, the non-invasive type of diarrhea like Vibrio Cholera and the enterotoxogenic Escherichia coli, the second type is the invasive type of diarrhea, where there is a physical damage to the gastrointestinal tract. And when you do a stool analysis, you will see your red blood cells in the stool, as well as fecal leukocytes. And this is extremely important to know when we do a stool analysis. You have to remember that. You have to look for red blood cells, white blood cells. Here, if those are present, this is invasive. If not, this is a non-invasive type of a diarrhea. And on top of the bacteria that is associated with that is the Shigella species. And we discussed that in the first lecture. Shigellosis, and like Shigella dysentery, for example, and the other types of Shigella. And this is the first thing that we have to think of when we do stool analysis. Also, Escherichia coli can be associated with here an invasive type of a diarrhea, and we call that enteroinvasive Escherichia coli. We have other one, we call it enterohemorrhagic Escherichia coli. So enteroinvasive and enterohemorrhagic Escherichia coli. Also, here we have the Salmonella enteritidis. By the way, Salmonella is the most common cause of food poisoning that usually comes from chicken. So if our food is contaminated here with chicken here feces, we could be infected with here the Shigella in particular, as well as with others as well. So Vibrio parahemolyticus is another bacteria that is associated with invasion to the gastrointestinal tract. Salmonella, then enteritidis, and then here the others, like also Clostridium difficile bacteria, and the Clostridium difficile causes a problem we call it pseudomembranous enterocolitis, and I'm sure you have heard about it here in abuse of antibiotics. So when we abuse antibiotics, it kills all the normal flora in the GI tract, leaving behind the ones that are resistant. One of them is the Clostridium difficile that causes pseudomembranous enterocolitis, and we have to treat that also with other selective antibiotics. And the others also here, like the Campylobacter jejuni, can be associated also with an invasive type of a diarrhea. So Campylobacter then, Shigella, enteroinvasive, Escherichia coli, Vibrio parahemolyticus, then and here you have to remember those and to differentiate them from the non-invasive type of a diarrhea. And remember, fecal leukocytes is the key for the identification of those pathogens, as well as red blood cells and stool analysis. So one could ask, what about Salmonella typhi? Can Salmonella typhi causes diarrhea? And the answer to that is, of course, yes. Salmonella typhi can infect the reticuloendothelial system and can be associated with severe hemorrhagic type of a diarrhea. It's not necessary. Sometimes could be associated with constipation as well, but can be associated with hemorrhagic type of a diarrhea. Very important here to remember Salmonella typhi and infection to the gastrointestinal tract. Yersinia enterocolitica, Campylobacter fetus, and Vibrio vulnificus. It's not just Vibrio, Vibrio cholera can be associated with non-invasive, but the Vibrio vulnificus here can be associated with an invasive type of a diarrhea. So it's extremely important here to isolate the organism so you can make the diagnosis and what is the type of the causative agent that's associated with diarrhea. So in order to make a diagnosis of the infectious agents, whether they cause a invasive type of a diarrhea or a non-invasive type of a diarrhea, we have to collect a stool specimen, and the collection has to be as soon as possible. The sooner the better, because if we are delayed, then the possibility of being contaminated is much higher. It's not just that, but we could take here swabs, fecal swabs, or rectal swabs. You can take, especially in Vibrio cholera. So it's not just the stool, but swabs. Rectal swabs can be used also to make the diagnosis. So remember that rectal swabs, we use it in cases of epidemics of cholera in particular. Then the rule of the thumb is to collect the specimen as soon as possible. Very, very important. The container has to be clean, because it could be contaminated with other agents, and it has to be covered with a tight lid, because if it is loose, it could be contaminated with microorganisms and here give you false positive results. Specimen should not be collected here with the urine. The specimen should not be mixed, because the urine could contaminate the specimen, or it must not have barium meal and enema, following here an X-ray done to the gastrointestinal tract. They use barium enema or barium meal, so it should be washed and should not be contaminated sorry, with barium, because it could give you a false positive something. You could be mistaken with other microorganisms. So very, very important here to remember that you should not have any barium here in the specimen. the rule of the thumb that the specimen should be transported to the lab as soon as possible, less than in 2 hours, and within 2 hours. Very, very important to get that, the sooner the better. Then after that, we have to prepare the media that we need to use to isolate the infectious agents. So the media that we are going to use, it depends here on what is our expectation. Is it an invasive type of a diarrhea, non-invasive type of a diarrhea? What are the organisms that we expect here in the stools? Very important to know these. Some of the media that we could be using to isolate the O157 strain of the Escherichia coli, media that contains the sugar sorbitol. So the regular Escherichia coli, the non-pathogenic Escherichia coli that's present part of the normal flora, usually ferments the sugar sorbitol, while the O157 strain here of E. coli usually does not ferment the sorbitol sugar. So this is biochemically we can use it for identification. Here the H7O157 strain does not ferment the sorbitol sugar. If the sorbitol sugar is fermented, it is not a pathogen. This is really very, very important here to know. So here we said we can use selective media for the isolation of the Yersinia here, Yersinia enterocolitica, and the selective media that we are using, we add antibiotics to inhibit the normal flora that's present in the stool, and mainly we use second and third generation cephalosporins here, like for example the cefzolidine, here argazan, novobiacin as well, we call it SIN. This is to get rid of the normal flora in the stool agar. And then we incubate that at room temperature usually. So we will isolate the pathogens, and the rest of the normal flora usually is inhibited by these antibiotics. So it is selective and differential, and selective for those pathogens, and differentiate even the species, like for example the Yersinia enterocolitica, for example, from others. The colonies will appear as bull's eyes, and clear, as if the eye, like the eye of a bull, with red centers and transparent here borders. So the borders will be transparent, and in the middle you have red dots almost. This is selective for the Yersinia. So we have so many media that we can use for the isolation of these pathogens, like the Yersinia, and the SIN agar is a selective agar that we use it for the Yersinia, And you can see here the colonies. As we said, the bull's eye appearance here with the transparent periphery of these colonies. This is selective for Yersinia. So for the media that we use for the isolation of the pathogens in the stool, like for example the McConkey agar, and we concentrate on the lactose non-fermenters. We could use also other media like the hectine enteric agar, also for Salmonella and Shigella, hectoin we call it. Here usually they are non-fermenters. So we have to select those non-fermented colonies, and then we have to look for the Salmonella or Shigella or the other pathogens here. So lots of media really we can use for the lactose non-fermenting colonies that we need to isolate and makes the pathogens here. For example, here the media that we use, hectine enteric, for example, we can pick up the green colonies for Shigella. And we then ignore the lactose fermenting colonies. So the non-fermenters usually are the ones that we are concerned with. So the rule of the thumb here is then to look for the lactose non-fermenting colonies in most of the media that we use for the isolation of the enteropathogens. Salmonella, Shigella, for example, all of them, they are non-fermenters. This is while the others that are fermenters, usually they are not pathogens. Very important. This is the rule of thumb. But we have to look for the Escherichia coli, the pathogenic Escherichia coli that we have talked about. Very important to remember. So the rule of the thumb, then you have to remember that in most of the media that we use for the isolation of those pathogens is to look for the lactose non-fermenters. Very, very important to remember that, whether on McConkey, XLD, hectine enteric media, remember lactose non-fermenters. So then you have to remember the rule of the thumb, that we have to look for the lactose non-fermenters in the media that we are using, whether it's a McConkey agar, HE agar, or whatever. So the non-lactose fermenters are the one that we are concerned about, while the others that are lactose fermenters, whether they are yellow or any colors that they have, then we have to ignore those, that they are not what we are looking for, the pathogens that are associated with infection to the gastrointestinal tract. So the other pathogens then, like Campylobacter, and the Campylobacter, it looks like by gram stain a comma-shaped colonies. So it is so important to look for those as a gram-negative comma-shaped colonies when you isolate those from the selective medium. Campylobacter jejuni. So it is so important then to identify those pathogens from the rest. Campylobacter, for example, is usually oxidase positive organisms to differentiate them from members of the Enterobacteriaceae, and also like those of Vibrio Cholera. So it's extremely important to know their oxidase reaction. Also, growth at 42 degrees centigrade can differentiate those if they can grow at 42 degrees centigrade compared to others. If they are not, then we can call them as Campylobacter species. Or if they do grow at 42 degrees centigrade and oxidase positive, then we have to report them as Campylobacter species. So it's extremely important then to do the oxidase testing for those to differentiate them from members of the Enterobacteriaceae, and growth at 42 degrees centigrade, comma-shaped colonies like Campylobacter. So very important to do these types of testing in the identification of those pathogens. So growth at 42 degrees centigrade, oxidase reaction, and gram stain, very, very important in their identification. So this is the colonies that they appear on this selective media, glistening type of colonies that are oxidase positive, for example, and then, as I said, growth at 42 degrees centigrade to be reported as Campylobacter jejuni, for example. What about the Helicobacter pylori? We talked about Helicobacter and how Helicobacter can produce a urease enzyme. This is very, very important here in their identification. And so it changes the pH from acidic into alkaline. So you can take a swab from the stomach, and very, very important here to look for the urease enzyme for Helicobacter for their identification. Helicobacter pylori. So the Helicobacter pylori, then if you take that from the stomach, you can see them slightly curved here, so they differ from the rest of the bacteria. And the key point in their differentiation is the urease enzyme, and change the pH here of the stomach that makes them grow. This is extremely important to know. So a black bacteria and slightly curved that are taken from the wall of the stomach has to be thought of as Helicobacter, and if it is urease enzyme positive, you can confirm the diagnosis, as simple as that. So you can then, very important to differentiate those bacteria from the other pathogens, like Vibrio Cholera, for example, here mainly by the comma shape or the curved type of rods, and the oxidase type of a reaction. So when you see those, you have to think of those pathogens, as simple as that. So in isolating Vibrio Cholera, we have to use a selective media after using a rectal swabs. Here an alkaline type of media, because the pH is usually between 8 to 9, and then we isolate them on a selective media, like one we call it TCBS, thiosulfate citrate bile sucrose agar, and then they appear yellow in color, as simple as that here. So this is selective media, the TCBS, for the isolation of Vibrio cholera. So the other tests that also we can do in the lab to differentiate the Vibrio cholera from other pathogens, like Aeromonas, for example, is what we call the string test, where the string test, when this is applied, you can see that here more of an elastic and sticky type of a reaction, and positive in Vibrio, while to differentiate it from Aeromonas, for example, and Pseudomonas shigelloides, which usually are negative. This is very important. We can use that in the lab for differentiation. So members of the Enterobacteriaceae, we can use biochemical tests here for identification. Very important to know that the pathogens is usually lactose non-fermenters. So non-lactose fermenters are picked up, then we do other biochemical tests for identification. So you have to know their original color. Here, that's the sugars are not fermented, for example, to compare them with the pathogens, for example. So it depends on the biochemical test that you are using. So in the biochemical tests that we use in the lab, a very important tube, we call it the TSI, or the triple sugar with iron. Here that contains the sugar glucose, and then we have lactose or sucrose as well. And so you have to know whether it's a lactose fermenter or other sugar fermenters, whether it's a glucose fermenter, or for example it can utilize the peptone and change that here into an alkaline. So the changes that we could see in these tubes, either no change, that means slant here, and the second one is the bottom. And the bottom is that we look for fermentation, for example, and the top usually for here oxidation mainly. So when no change over no change, it means no fermentation here at all, and no oxidation. So it's an inert type of a bacteria. If the slant is red and the butt is no color change, we put K over no change, it means here just simply fermentation of the and the peptone is used aerobically here only. But if it is red over red, at least here we can tell that there is no fermentation. Red over red, here we put that K over K, here no fermentation, and the peptone is catabolized only here. So when we start seeing yellow, then we can see here, start with the fermentation process, like red over yellow. So the red is at the slant. Here we put that as K over A. So the glucose, for example, is only fermented, and the peptone is catabolized. And the peptone usually it gives you a high pH, so it will be catabolized and give you the red color. Well, if it's yellow, that means it's a fermentation. Here, red over yellow, for example, with bubbles here, K over A, bubbles, that means there is a gas. So the glucose is only fermented, and carbon dioxide gas usually is produced. And the red over yellow here with black precipitate, the black precipitate indicates H2S, as simple as that. That there is a hydrogen sulfide that is produced, and this has a meaning. So K over A with H2S, glucose fermented, only H2S produced. So the black color means hydrogen sulfide here. And here, if it is red over yellow with bubbles زي ما حكينا, that means the glucose is fermented, and only the glucose here and H2S is produced. So the black color means H2S always. So here the yellow over yellow, that means fermentation here, as simple as that. We put that A over A, that means acid at the slant and acid at the bottom. Here glucose, and here lactose is fermented. And so usually starts with the glucose and then goes into the lactose. So glucose and lactose are fermented. So if it's all yellow, here it means lots of fermentation process that's going on. Yellow, here over yellow with with bubbles, here it means that the lactose is fermented and gas is produced. Here we see the bubbles means gas, which is CO2. And yellow over yellow with black precipitate, we put that A over A, the slant and the butt, lots of acids, H2S produced, become black, glucose and lactose, fermentation, and H2S is produced. So those are the ones that we rely upon in the identification, and then you have to remember that whether it's red or yellow. Yellow, it means fermentation. Red, it means that the peptone is catabolized more, the pH is higher. The red means high pH. Yellow, it means low pH or acidic. The first reading for the slant and the second for the button. And so this is really very important in the identification process. So this is, for example, the tube that is not, or it's just here a black over no change. Here K over A, K, and it means alkaline, A acid, and G means gas that is produced. K over A negative, that means no here bubbles or no gas that is produced. And this is a control, for example, to see the original colors. So you can see here the black color means H2S. Here no black, that means no H2S. The bottom is yellow, so it's lots of fermentation. Very, very important. And this is the reference a tube or the control. This is really very important to know in the reading process. The slant, the first reading, the second for the button. Black, H2S. Gas, bubbles, H2S usually, and gives you lots of information, the TSI tube. Glegular iron agar, we call it, or TSI, triple sugar iron. The glegular iron agar, it contains only two sugars, which is glucose and lactose. The TSI, the triple sugar, glucose, lactose, and sucrose at the same time. So glegular is the one that we are using the most. So remember the original color, no fermentation here at all, and black discoloration, it means H2S production, and bubbles, it means carbon dioxide that is produced. So remember that here bubbles, CO2, red, pH is high, yellow, pH is low, means acidic. So this is the information that we can get from the glegular iron agar. So the other test that we use for the identification of members of the Enterobacteriaceae, and especially the lactose non-fermenters, is the nitrate utilization test, as well as the citrate utilization. So if the citrate is utilized, it's going to give you a deep blue in color compared to the normal color. Here, if it is not utilized, then it will stay as it is. So remember that growth or change of color to the deep blue, it means citrate is utilized, as simple as that. So another important test is the urease hydrolysis by the production of an enzyme here, and this is extremely important to differentiate bacteria that produces the urease enzyme from ones that they don't use the urease enzyme. We call it Christensen's urea. Christensen's urea media, and usually when the urease is produced, it changes the pH here into a higher pH, so it becomes alkaline and changes the pH, the change of the color into deep red. So deep red in color, it means here urea is hydrolyzed, or urease enzyme is present. No change of color, that means that no urease is present. So Proteus, for example, produces the urease enzyme, which is very, very important here to know if the bacteria produces the urease or not. No change of color, it means urease is not present if we are looking for the Christensen's urea media. So those then biochemicals are extremely important for the identification of the enteric organisms, and to differentiate them from the rest of the normal flora. So if we look into a media, we call it the SEM media, for example. S stands for sulfide here, so the black discoloration that we see indicates the presence of sulfide. Here I, we call it the presence of indole here, and M, motility. So the M is the simplest. So when the bacteria is motile, you will see it turbid, and if it is non-motile, it will be clear, as simple as that, or it doesn't move from the inoculation side. And the indole, when we add what we call Kovacs reagent, it gives you a red color. So the red color indicates the presence of the indole. No, when we add the Kovacs reagent and no change of color, it's indole negative. So those are the biochemicals, and one media that can give you those three tests together, we call it the SEM media. So S stands for sulfide, and M for motility, and I for indole test. So again, this slide shows the SEM media again, here for sulfide production, indole, and motility. You can see here when you inoculate the media how bacteria moves from the site of inoculation. That means it is mobile. If it doesn't move, then this is non-mobile or called turbid in color, معناتها motile. No motility, it's it means it's a non-motile. And when you add the Kovacs reagent and gives you a red color to the surface, that means it is indole positive. Black color, it means here simply sulfide positive. So in making the differentiation between an invasive and a non-invasive type of a diarrhea, the most important thing in the stool analysis is to see whether the stool contains red blood cells and white blood cells, for example. So if red blood cells and white blood cells are present, this is an invasive type of a diarrhea. If they are not present, that means it's a non-invasive type of a diarrhea, and you can here differentiate or tell what are the possibilities of the invasive versus the non-invasive type of the diarrhea. So again, it's extremely important then in the differentiation of an invasive versus non-invasive type of diarrhea. Here is the presence of white blood cells and red blood cells. We call them fecal leukocytes, fecal red blood cells. This is very important finding here in the stool analysis. So the consistency of the stool is extremely important also for identification, whether it is formed, that means like somebody was having constipation, or soft, it means that it has more fluid into it, and then loose, more watery, for example, and then watery, that you can see it, severe diarrhea. So in those, it's extremely important where you are going to find here the cysts, for example, or the trophozoites. So the trophozoites, for example, can be seen mainly in the watery type of a stool, compared to the cysts that you can see them in the formed, for example. So in the trophozoites, you see an acute phase of an infection, while the cyst is somebody who could carry, for example, a protozoa in his or her gastrointestinal tract. So the consistency of the stool is important. Remember those, whether it's watery or loose, soft, minor liquidy, or formed, more of a constipation. So the consistency of the stool is very important. It's extremely important to differentiate in the stool analysis here if the patient carries the pathogenic amoebas, in particular like entamoeba histolytica, and the non-pathogenic amoebas like Entamoeba coli, for example. And the only meaning, if you have in a stool analysis the non-pathogenic amoebas, that this patient has been exposed to fecal material, as simple as that. So Entamoeba histolytica and Entamoeba coli and the other non-pathogenic amoebas, only indication their presence that the patient got exposed to fecal material that contains those non-pathogens. So here, for example, if we look into a cyst stage of Entamoeba sorry, coli and Entamoeba histolytica, that in Entamoeba histolytica, the cyst stage contains up to 4 nuclei, and the nuclei has nucleoli, that is bull's eye. That means the nucleoli is present in the center. So any amoeba that the cyst contains more than 4 nuclei is, by definition, is not Entamoeba histolytica. So in this slide, it shows a cyst stage up to 4 nuclei here of Entamoeba histolytica, and chromatin bars. And the chromatin bars here indicates aggregates of ribosomes here, and the chromatin bars they are not blunted. So this is a clear evidence of a cyst here of Entamoeba histolytica identification. So it's extremely important then to differentiate between the pathogenic amoebas, which is Entamoeba histolytica, versus the non-pathogenic amoebas like Entamoeba coli, Endolimax nana, Iodamoeba botulinii. All of those are non-pathogens that we need to differentiate from Entamoeba histolytica. And this slide here shows here, for example, Entamoeba histolytica, the trophozoite contains red blood cells, because here those are pathogens, and they are associated with an invasive type of diarrhea. So if you see red blood cells within the trophozoites, it indicates Entamoeba histolytica, while Entamoeba coli and others, they don't contain here red blood cells. Second is the nucleoli here, if they are present, if you have more of a nuclei, 4 nuclei, for example, by definition, it's not Entamoeba histolytica, while Entamoeba histolytica has up to 4 nucleoli, for example. And of course, the shapes, as I said, of the bars that contains here aggregates of ribosomes. Very, very important to know. Chromatin bars, we call them. So it's extremely important then to differentiate between the pathogenic Entamoeba histolytica versus the non-pathogens regarding the chromatin bars and the nucleus. And remember that the nucleus has nucleolus, we call it the bull's eye in appearance, and the chromatin bar is usually blunted rather than pointed, and the trophozoite contains usually red blood cells, indicating invasiveness. For example, this slide shows a collection of the non-pathogenic amoebas, and you can see that having more than 4 nuclei, by definition, it is not Entamoeba histolytica, and the chromatin material is usually irregular, compared to Entamoeba histolytica, where the chromatin material, they are regular in general. So the microscopic differentiation between those is extremely important. Entamoeba histolytica versus the non-pathogenic ones. Yeah, for example, this slide shows some of the non-pathogens, like the Endolimax nana, for example, and you can see the shape of the nuclei, and here the vacuole that they are having here. So the irregular here nuclei in this one, and large ones as well, indicates the Endolimax nana. Just you need to differentiate or say that this is not an Entamoeba histolytica. Maybe this will be enough for physicians at least. So as I said, it's extremely important then to differentiate between Entamoeba histolytica, the one that is associated with amoebic dysentery, and the non-pathogenic amoebas that they indicate only fecal contamination. And this is a sketch that shows here this differentiation. Trophozoite stage, for example, or the cyst stage, regarding the number of nuclei and the distribution of the nuclear material, extremely important to know. So in Entamoeba histolytica, the nucleus is bullseye, up to 4 nuclei in number, no more than that. We have one that is non-pathogenic, that looks like Entamoeba histolytica, but it's much smaller. We call it Entamoeba coli, for example, which is much smaller than that of Entamoeba histolytica. Entamoeba coli, you can see the irregular chromatin material here into the periphery, and more than 4 nuclei here. By definition, it's not Entamoeba histolytica. Here, and here Polykii, the same thing here, irregular chromatin here material, and the Endolimax nana, smaller, and the chromatin material is almost gone. Here clear here, and you can see the nucleus with the clear chromatin material at the periphery. This is almost pathognomonic compared with the pathogenic ones. So it's extremely important again to differentiate between Entamoeba histolytica and the other non-pathogens. It has to do with the number of nuclei in Entamoeba histolytica, up to 4, as we said, distribution of the chromatin material, the periphery, and Entamoeba histolytica, it's bullseye. The nucleolus usually is in the center, and the chromatin material is evenly distributed. This is very important to differentiate between Entamoeba histolytica and the non-pathogenic amoebas. Other protozoa that also can be associated with the severe watery type of a diarrhea, usually non-invasive type of a diarrhea, which is Giardia lamblia. And the Giardia lamblia is associated with disease, as you know, it's called giardiasis. Giardiasis, bound to the duodenum, usually blocks the absorptive surface villi and associated with severe watery type of a diarrhea. And you can see the trophozoite form as well as the cyst stage. The cyst stage, which is the infectious stage in the giardiasis, the name of the disease. So when you look at the trophozoite, you can see two nuclei, and the two nuclei, and then we have a sucking disc just around them that it uses it for attachment, and you can see the flagella, 3 pairs of flagella that it uses it for motility. So Giardia lamblia can be differentiated by its nuclei and the sucking disc. So as if it's a face as if that's wearing glasses in a way, and you can see the flagella that it uses for locomotion, propelling type of a motility. So remember Giardia lamblia and giardiasis. Here the cyst stage and the trophozoite stage. Also in stool analysis, sometimes in a protozoa called Balantidium coli that can have a trophozoite and a cyst stage, and also this one comes from contaminating food or water with pigs' feces. And sometimes you can see a macronuclei and micro nuclei, and this is very important. You can see those in the cyst stage or the trophozoite stage, Balantidium coli. Remember that. And the disease, we call it balantidiasis. Balantidiasis. So again, you can see the Balantidium coli that comes from pigs, the trophozoite form, and the cyst stage. And sometimes you can see a large one, we call it macronucleus, and micronucleus. So you could see sometimes two nuclei in the Balantidium coli, and it has a cilia, so it can this trophozoite can move by the organ of locomotion, which is the cilia of Balantidium coli. Also many other protozoa that also can be seen in stool analysis, which is the Cytoisospora here, and you can see the nucleus. It's an elliptical shape trophozoite, and you can see a cyst stage as well, and those also can be associated with diarrhea, and usually they come from animals. And some patients that they have severe watery diarrhea that are here caused by the Cryptosporidium parvum can be stained with the acid-fast staining. So in this slide, it shows you the cyst of the Cryptosporidium here in a patient who has a watery type of a diarrhea following a prolonged history of antibiotics usage. So remember that Cryptosporidium parvum. Here we use modified acid-fast staining here to stain those cysts, and you can make the diagnosis of those. To make the diagnosis of the diarrhea, Cryptosporidium parvum. And sometimes in parasitology, especially in protozoa, we could use the direct fluorescent antibody to make the diagnosis. So fluorescinated antibodies against the Cryptosporidium, for example, can be used, and you can the antibodies are going to bind into the cell wall of the cyst, so you can see it fluorescing. That means it gives you a light, and we can use that fluorescent antibody in making a diagnosis of many of these protozoa in fecal specimens. So you can see here the modified acid-fast staining here, that we can use it for others, like Cyclospora, for example, catayensis, can be stained here with the modified acid-fast as well here. So in many of those protozoa, we can use the acid-fast staining here to stain the cysts. Again, you can see the immunofluorescence here to identify the different cyst stages of a protozoa by using ultraviolet light, and they fluoresce, and they will give light when you hit them with a source of ultraviolet light. And this is widely used in protozoology, for example. Fluorescent antibody, fluorescinated antibodies against the cell wall of these cysts. And many of these protozoa here sometimes in patients whom they have like for example here some can be also applied by using the fluorescinated antibodies in the identification, especially here for the protozoa that can be isolated from the gastrointestinal tract in general. So fluorescinating antibodies can be used then in the identification of many of the protozoa in general. For example, in patients whom they develop severe watery diarrhea, have the Cryptosporidium parvum, can be diagnosed by using fluorescinated antibodies here, and can be by taking a biopsy from the GI tract. You can see the here the spores of Cryptosporidium, and then you can make the diagnosis accordingly. So the same thing here can be applied for other protozoa, like the Microsporidium. Also can be applied, and can use fluorescinated antibodies here for the identification of these protozoa in general. So it's not just a protozoa that can be associated with diarrhea in parasitology, but also worms. And these worms can be either round worms or even not just round worms, like the nematoda. We'll talk about them in just a second, but also tapeworms. We call them cystoda, and some of the schistosomes that we call the trematoda. All of those can be associated with diarrhea, and we make the diagnosis here by doing a stool analysis and seeing the type of the ova that is present in the stool analysis here to make the diagnosis. Capillaria philippensis, for example, this is one. The second here, for example, Enterobius vermicularis, or the pinworms, like a D-shaped here egg. We get that from the Scotch tape technique around the perianal region. You can see the ova. And of course, from stool analysis, Ascaris lumbricoides, very large number of eggs that has an albuminous here material on the surface of the ova, elliptical in shape. It is pathognomonic. And in Ascaris lumbricoides, you can see the albuminous jelly material around the ova. Very important to know. And those can be many different format. The hookworm type of an egg, also by doing a stool analysis, you can see them. And the Strongyloides stercoralis, for example, he also some of the nematodes can be seen by stool analysis. So in doing a stool analysis, here you can identify the type of the parasite, here whether they are roundworms or a tapeworm, or the some of the schistosomes can be identified by doing stool analysis. For example, these are some of the ova that can identify certain worms in the gastrointestinal tract, like for example the Taenia species, Taenia saginata or Taenia solium, دود الوحيدة. The shape of the ova, they are the same. They have striated type of a shell wall for the egg by doing simply stool analysis. And one called Hymenolepis nana or Hymenolepis diminuta can be identified also by the hairy-like type of structure that's present in the ova in a stool specimen. And in Hymenolepis diminuta, usually we don't see the hairy structure like those of the Hymenolepis nana or the dwarf tapeworm. And one that comes from dogs called here Diphyllobothrium latum. This is the fish tapeworm that comes here from eating raw fish and has the ability to absorb vitamin B12. So it causes here vitamin B12 deficiency. And one that we call the Dipylidium caninum, that also come from dogs and humans. So you can see many different examples of worms by doing simple stool analysis, and you can identify the type of the worm here by the shape of the egg. So many of these worms can be diagnosed by doing stool analysis, like for example Clonorchis sinensis. This one is usually present in the liver. Clonorchis sinensis, Clonorchiasis, or the Abstorchis viverini, for example, also can be identified, and the Paragonymous wistermani, here, which can be seen here in the lungs, and the eggs can be cuffed and then swallowed as simple as that. And here the schistosomes, like schistosoma, schistosoma here, aponicum, japanicum, sorry, schistosoma japanicum. Here the schistosomes can be identified by the location of the spike, where this is located. And the schistosoma mekongii and the schistosoma mansonii. Schistosoma mansoni has a lateral spine, to be differentiated from the others. About it could be around more than here 80 micrometers in length. And the schistosoma intercalatum also, and schistosoma hematobium can be seen by the terminal spine here, compared to schistosoma mansonii, for example, that has a lateral spike. So in all of these, you have to know the life cycle of those, and we will be talking in details when we talk about the schistosomes about these worms and the life cycle and the pathology that is associated with these worms. Other worms that also are important and can be diagnosed by doing stool analysis. We said the schistosoma hematobium. Here we talked about that, and the one with the terminal spine, fasciola hepatica, here worm. The egg is so large, it exceeds 140 micrometers in length. Fasciolopsis buschii, affecting the colon. Fasciolopsiasis, it causes a disease. And also the echinostoma species. All of those can be seen as part of the trematodes in the gastrointestinal tract. This slide shows some of the relative sizes of ova or eggs compared to the different types of the parasites. Maybe many of those you are not going to see all over your life, but some that are extremely important, like the schistosomes, schistosoma, for example, schistosoma mansonii, for example, compared to the other schistosomes, hematobium, schistosoma hematobium, the one that has a terminal spine, and the schistosoma here mansonii that has a lateral spine. And of course we have the schistosoma japanicum that sometimes barely you could see the spine in those. So the life cycle and the differentiation between those and relative sizes is extremely important to know in the diagnosis of these worms, for example. Tinea eggs, and the tinea that has the double shell, for example, so easily can be differentiated. Hymenolepis nana, Hymenolepis diminuta, for example, and the Fasciolopsis, for example, buschii, Fasciolopsis, Fasciola hepatica. Sometimes the shapes of the eggs they could be very close, and differentiation from the clinical presentation and the life cycle is extremely important. So in parasitology, it's extremely important in order to make the diagnosis of a worm is to look for the ova or the egg. And sometimes you might not be able to differentiate that from the rest, so you should have like an atlas to look at it in the lab and to compare that one with the ones that are present in the atlas, so you can make the diagnosis, and then following that, then you should start the treatment accordingly and the prevention. So in all of these worms, you have to know here the life cycle, how we do get infected, how are we going to make the diagnosis, and then what is the drug of choice that we need to use for treatment, and what are the preventive measures that we should be doing so we will not be infected with that again.